here at Staten Island University Hospital, director of the Comprehensive Breast Center. I'm going to be speaking, of course, today on breast cancer, which is near and dear to my heart. One, because I see my patients every single week, and we're dealing with breast cancer all the time, but also my sister had breast cancer a couple of years ago. And, like many patients that are diagnosed with breast cancer early, they go on to have very, very good prognosis and a very good outcome. So I'm just going to talk. I'm sure many of you in the room either know somebody with breast cancer, you may have suffered from breast cancer, or had precancerous lesions on your mammograms that have been taken out. So breast cancer is so common amongst women, and certainly very, very common amongst women in Staten Island. So I'm just going to describe a little bit about what breast cancer is, about the screenings for breast cancer, treatment options. I'll be showing some slides at the end, which will be showing some mastectomy patients that have had reconstruction. I want to show these pictures as more of a means to say that we've come so far in regards to treating breast cancer that women not only can be treated for the cancer and can live cancer-free for many years, but they can also have a very good cosmetic outcome. So basically, the anatomy of the breast, as you can see, the milk is made up of, the breast is made up of milk ducts and milk sacs. So the lobules, which you can see in this area, the lobules, are the milk sacs. So that's where the milk is produced when we start breastfeeding. And then the milk travels down through the milk ducts, and the picture in the corner shows what a normal milk duct will look like. Breast cancer basically means a progression of these cancer cells that have become abnormal. So typically the progression of disease occurs when you have a normal duct. Some women, especially women with fibrocystic breast disease, may develop ductal hyperplasia, which is an overgrowth of cancer cells, an overgrowth of normal cells within the milk duct, but they're still completely normal, and the risk of cancer if you develop this condition is really minimal. They can then begin to progress to atypical cells, or sometimes called atypical ductal hyperplasia. And this we now consider a precancerous condition, because these patients, or women that have this disease in their duct, eventually that lesion in the breast, or those atypical cells, can progress onto cancer cells. When they do progress onto cancer cells, they can begin as ductal carcinoma in situ, which is basically at this point cancer. So some people refer to this condition as precancerous, but it's not. These are cancer cells that have started to grow in the duct. They basically are taking over the good cells, which is what cancer basically is. It's bad cells overtaking good cells, and it's now occupying the milk ducts. If it breaks through the milk ducts, then it is called invasive ductal carcinoma. And that's when those cancer cells then have the ability to get into the blood vessels and the lymphatic vessels in the breast and spread to other parts of the body. The process can also occur in the milk sacs. So we were talking about the milk ducts. So in the milk sacs, you can have a process called atypical lobular hyperplasia, and this can progress onto lobular carcinoma in situ. A lobular carcinoma in situ is a little bit of a misnomer because it implies that it's cancer, but it's actually not cancer. Atypical lobular hyperplasia and lobular carcinoma in situ are lesions that occur in the breast that tell us that this patient is at very, very high risk of developing breast cancer. The breast cancer may not actually develop where that lesion is. The breast cancer may develop in the other breast, may develop in a different part of the same breast that we find the atypical lobular hyperplasia or the lobular carcinoma in situ. Typically, we do take out these lesions, but only because we want to make sure that they don't already have an associated cancer, or that the pathologist hasn't been able to give us a complete diagnosis of what's going on in that area. But it's not something that we have to typically go on and treat as a cancer. So breast cancer, excluding cancers of the skin, breast cancer is the most common cancer amongst women, and it is the second leading cause of cancer deaths in American women after lung cancer. In 2010, there were an estimated 209,000 new cases of male and female breast cancers. In New York and New Jersey, there were 21,000 women diagnosed with breast cancer. And in 2010, an estimated 2,050 cases were diagnosed in men, which accounts for 1% of all breast cancers in the United States. So unfortunately, yes, men can be afflicted with breast cancer. When we look at the risk of breast cancer through the ages, although many of us seem, I know I certainly feel it in my practice, find a lot of women seem to be diagnosed now in the ages of 30s and 40s, and we are seeing an increase. But generally, the risk increases exponentially as we age. So in your 20s, the risk is 1 out of 2,100. As you get into your 40s, it then comes up to 1 out of 69. As you go into your 60s, and then overall, by the time you get to 70, the risk of developing breast cancer is 1 in 7. Risk factors for breast cancer: if you've had a personal history of breast cancer and ovarian cancer, as we talked about earlier, there's a family history of breast cancer. Again, very important to know your family histories. If you've had a previous biopsy showing atypical hyperplasia or carcinoma in situ, if your periods began before the age of 12, and if menopause started after the age of 55. Why is that? Because that's the more time where women are exposed to estrogen, which is the biggest culprit in regards to causing breast cancer, the more likely they are to develop cancer. So the longer our exposure to estrogen, the more likely we are to develop cancer. Never having children, having the first child after the age of 30. If a woman has a mutation, genetic mutation of BRCA1 or BRCA2 genes. If a woman drinks heavily, this says 1 alcoholic drink per day, but in reality what the studies are really finding is that women who drink 4 to 5 drinks per day, so it's really considered heavy drinking, are at a higher risk for developing breast cancer. And then of course being overweight after menopause, of course, is a major risk factor. And as once again, once you get through menopause, our ovaries are no longer producing estrogen, but our fat produces estrogen. So the more fat tissue we have, the more estrogen we have, the longer we are exposed to estrogen, which puts us at risk of breast cancer. Breast cancer survival, these are overall rates, so this is basically looking at all stages, but it's 89% at 5 years after diagnosis and 81% after 10 years of diagnosis. So that means 81% of women after the diagnosis of breast cancer in 10 years will be alive. So we consider breast cancer a cancer that has a good prognosis, and that's why we emphasize early screenings and catching breast cancer at an early stage, because we can consider it curable. Again, if you catch breast cancer early, better chance of survival. The American Cancer Society recommends these guidelines in regards to early detection. Women between the age of 20 and 39 should have a breast exam by a physician every 3 years, a monthly self-breast exam, and women over the age of 40 should begin having annual mammograms along with annual clinical breast exams. So self-breast exams, these are done obviously by the woman herself. We recommend doing these breast exams about 1 to 2 weeks after your period, because that's when your breast tissue is the least reactive by hormones. So when you start getting closer to your periods, your estrogen levels are increasing. All the cysts and all the lumps and bumps in your breast are really going to start to become obvious. Your breast tissue swells. It's really difficult to do a breast exam, and you're bound to find something in your breast if you do it just before your period. So after your period, do a breast exam. Typically lying down in the shower is the best way to do it. And the idea is just to get to know your breast and to get to know what your breast tissue feels like. Because if you do feel a new lump, then you'll know. It's not one of these things that you kind of have to sit there and ponder. You will notice, but it's a matter of just really getting to know what your breast tissue normally feels like. Clinical breast exams are done by a physician. It's very important to start doing this. Again, once every 3 years is sufficient, and you're before the age of 40, but certainly after the age of 40, you need to have this done by a trained physician, whether that's your gynecologist, your primary care doctor. You need to make sure that it's a sufficient breast exam where they spend a few minutes really examining your breast thoroughly and checking underneath your arms, and also checking for nipple discharge. And then mammograms should be done starting at the age of 40 for most women. Now, women that are high risk, women that have family histories, women that maybe have fibrocystic disease, they may end up with having a baseline mammogram at the age of 35. And some women, if their mothers have had breast cancer, then we start the mammograms 10 years before the mother's diagnosis of breast cancer. So if your mother had breast cancer at the age of 40, then your mammogram should begin at the age of 30. Obviously if she was 55, then your mammograms would begin at 40 along with everybody else.